Good evening, everyone. Good evening. Welcome to the Miracle of Living, tonight's lecture on stroke. My name is Frank Miles. I'm a member of the committee that plans these lectures. Let me go through a little bit of housekeeping first. First of all, turn off your cell phones, please. It's really very easy. Even I can do it. You take out your phone, and in the case of an iPhone 10, you flick this little thing there, but your mileage may vary on that. Okay, the restrooms are out the door and straight across the hall, so that's pretty easy too. Now, the order of business tonight will be first, we will have the speakers, then there will be a brief intermission, and following that, we will have the question period. Hold all your questions for the question period. We take written questions only. During the intermission, members of the Miracle of Living Planning Committee will circulate among you with pens and paper for those who need them, and they will also collect the questions and bring them up here to the podium, and then the moderator will pose the questions. So, speakers, intermission, questions. All right, now I mentioned a moderator. We actually have one here, good enough. Her name is Hena Saeidi. She's a nurse practitioner in neurology. I just met her and she seems very nice. So please welcome her.
Okay, good evening, everyone, and welcome to Torrance Memorial's Miracle of Living lecture on this important topic of stroke. My name is Hena. I am a nurse practitioner here in the neurology department at Torrance Memorial Medical Center. It's a pleasure to be here moderating this event about this discussion with our multidisciplinary panel. So a lot of you might know this already, but stroke remains one of the leading causes of disability worldwide, something that we deal with at work all the time, every day here. However, when there are early interventions and treatments, like rapid treatments, we are able to improve those outcomes dramatically. Here at Torrance Memorial, we're a comprehensive stroke center, so we take our stroke patients very seriously. In the emergency room, we have a whole protocol that we rapidly call a code stroke for, and we have our emergency team to thank for that. So tonight, our goal is not only to provide information about this, but to also kind of inform you guys about what to do to prevent stroke from happening in the first place. So before we begin, I'd like to thank all of you guys for coming and taking the time to join us, whether that's in person or via Zoom. So if you have any questions, save it for the end when we will open the floor to discussions and questions after the presentations. I do like to introduce our panel of speakers, Dr. Joseph Friedrich, Dr. Jonathan Chou, James Vargas, and Junith Castillo Rodstein. Our first speaker will be Dr. Joseph Friedrich from emergency medicine. He obtained his undergrad degree from Georgetown University School of Medicine. He completed his emergency medicine residency at Harbor UCLA Medical Center, where he served as the chief resident during the COVID pandemic and was a recipient of the Medical Student Teaching Award. He currently practices emergency medicine here at Torrance Memorial Medical Center.
All right, let's see if I can get this up. Okay, thank you guys so much for being here. We are excited to talk about stroke. Let me see if I can get my slides up. So I am Joseph Friedrich. I'm one of our ER doctors here at Torrance. And my portion is just going to cover what we do in the emergency room for stroke. So I am keeping it very surface level, and thankfully we have other experts here who are going to go more in depth. So 3 things that I want to cover. Number 1, what is a stroke? Number 2, a little bit about how we recognize some of the signs and symptoms. And then number 3, what we do if we're actually concerned one of our patients has a stroke. Okay, so what is a stroke? So the stroke is analogous to a heart attack of the brain. So essentially, a stroke happens when part of the brain suddenly loses blood flow. So just like every other cell in our body, our brain constantly needs blood with oxygen to function. And the second it doesn't have that, brain cells can start to die. So that's why, and we're going to hit on this multiple times throughout tonight, if you're feeling signs or symptoms of stroke, which we'll discuss, we want you to come to the emergency room quickly. We want you to call 911. A stroke isn't one of those things where you want to sit at home and wait on it to see if it gets better. If you think you're having symptoms, we want to know about it. So brain cells constantly need oxygen, minutes matter, and it's always an emergency. So there's no such thing as waiting out a stroke. So there are 2 main types of strokes to go over: an ischemic stroke or a hemorrhagic stroke. An ischemic stroke you can think of like a blocked pipe. This is analogous to a heart attack. The arteries take blood from our heart into our brain. And if one of those arteries or one of the pipes gets blocked, that's called an ischemic stroke. The pipe is blocked, blood cannot flow to the brain. That's the most common type of stroke, about 85%. Hemorrhagic strokes are actually when there's bleeding into the brain. So when a blood vessel bursts and bleeding happens into the brain. And that is also bad as well, because when there's bleeding in the brain, that can exert pressure on the brain, which interferes with blood flow as well. So depending on what type of stroke you have, that determines how we're going to treat it in the emergency room. And like we said, even bleeding strokes deprive parts of the brain of oxygen. All right, so these are some of the symptoms. Maybe you've seen posters of these, maybe you've seen public service announcements for them. I'm just going to go over a very big picture, some of the things we look for in the emergency room. So balance or loss of coordination in the upper left corner there. If people feel that suddenly they can't walk, they try to walk or they fall over, this can be a sign of a stroke, either from weakness in an arm or leg or a stroke in the part of the brain that helps us with balance and coordination. That's called the cerebellum. Face, this is probably one you've seen on posters frequently. Droop of the face, meaning it's asymmetrical in the lips or the eyes. That's a common presenting sign of a stroke. Speech, if someone starts stuttering their words, slurring their words, can't speak at all, or if someone stops being able to understand you. Sometimes we can have strokes in parts of the brains that receive language. So even though someone's not having trouble speaking, if they suddenly aren't able to understand language, that can be a sign of a stroke as well. Eyes. So this one can be tough because we can also have problems just in the eye itself that aren't a stroke. But if we have a stroke in the part of our brain that deals with vision, that can present as someone suddenly losing vision. And then arm, this is also a common sign. Someone stops the ability to use their arm or a leg or their hand. That can be a sign of a stroke. And then the last one is time. So the acronym is B, fast, balance, eyes, face, arms, speech, and time. So if you notice these symptoms in yourself and your loved one, call 911. Don't drive yourself if you're having symptoms. Either call 911 or have someone drive you to the emergency department. Okay, so not to be too dramatic, we just really want to hit on this. Every minute counts in a stroke. Every second counts. Every second the brain there's trillions of neurons and connections in our brain. Every second they lose blood flow. Some of these connections can die. And for every hour of untreated stroke, this is kind of a big approximation, but you could think of it like the brain is aging 3.5 years for every hour of untreated stroke. Stroke is thankfully, in a place like LA County, we have a lot of resources available for stroke. And the process in the emergency room for us often starts well before patients arrive in the emergency department. So at Torrance Memorial, we are a comprehensive stroke center, which means we have experts who can handle all sorts of strokes here. So we are notified very quickly after 911 arrives on scene at someone's house. If the paramedics are concerned someone is having a stroke, we get alerted well in advance so that we can prepare for that patient's arrival. So EMS, or Emergency Medical Services, responds. We prepare in the emergency room, and then treatment begins once you or your family member gets to the emergency department. Okay, I think this is probably one of the other biggest things we want to hit on. It is a true team sport in the emergency room. As the doctor, I'm actually usually the last person to know when staff thinks someone is having a stroke, because it's usually our nurses that make the diagnosis first. When someone walks into the front door, it's the nurses who triage the patient, and if they're at all concerned that someone is having a stroke, they grab one of the doctors immediately. So it's really our nurses we rely on for rapid diagnosis of strokes. I would say probably in the past year, there's maybe been only 1 or 2 patients where I'm the person who's raising the concern for stroke. It's usually always done by our paramedics or the nursing staff before I or any of my colleagues, doctor colleagues, even have a chance to see the patient. So nursing staff are typically the first healthcare workers to identify that a potential stroke has arrived in the emergency department. And then once nursing identifies the patients, they grab me or one of my colleagues and we evaluate the patient. If we agree, then we activate what's called a code stroke. Everything in the hospital that's important is a code. Code heart attack, code stroke, code blue. So the reason we activate a code stroke is it actually starts this whole process in the background. When we activate a code stroke, our stroke neurologist, someone like Dr. Chou, is paged, and they call back rapidly within 5 minutes to talk about the case with us. Because we need to get pictures of the brain when someone's having a stroke, which we'll go over in a second, the CAT scan is notified that we have a potential stroke coming in, so they stop anyone else from coming to CAT scan and reserve a CAT scan immediately for the stroke patient. And then similarly, point 3 at the bottom there, prioritize labs. The laboratory is alerted that we have a potential stroke patient coming in because there are some blood tests that they have to rapidly run in stroke patients. So the lab is notified to prioritize this patient's blood work as well. So once we have activated a code stroke, the next thing we do is get pictures of the brain. And this is because we need to figure out what type of stroke this is. So back when we started, we said there were 2 types of strokes: ischemic strokes, which is the blocked pipe, or hemorrhagic strokes when there's bleeding into the brain. And that's the reason why very rapidly after identifying that someone has a stroke, we rush them to the CAT scan because we want to see, is this bleeding into the brain or is this blockage of blood flow? Because that's where the treatment really diverges. There's 2 different treatments depending on the type of stroke. So the first test we do in the emergency department is a CAT scan. And this is because it's fast. Within 10 minutes of getting a CAT scan, we'll have the result, and we'll know immediately whether or not someone is having bleeding into the brain. And then we'll get to this in the next slide. But if someone's not bleeding, that's when we can make the decision whether or not we want to give the clot-busting medication. That's the special medicine that can burst open that blocked pipe. Another test that's done for strokes is called an MRI. And maybe some of you have heard of MRI. This is the more high-depth, in-depth study that really looks almost at a cellular level of what's going on in the brain. So from the emergency room, we don't typically do the MRI because that's usually done a little bit later to look if someone did have a stroke, what type of stroke was it, when exactly did it happen. The MRI is a more in-depth picture, and we typically aren't getting that in the emergency department. And part of the reason is that we don't get it is because it does take a while to get. An MRI can take 15, actually sometimes 30 minutes to an hour to get done. And a lot of times we need to make decisions more quickly than that if we're concerned someone's having a stroke. Oops. Let's see what I did here. All right, thank you. Okay, so if we've done someone comes in with a stroke, we've done the CAT scan, and we see there's no bleeding in the brain, so we think it's a blocked pipe. There's 2 treatments we can do. The first one is a medicine, which is commonly called a clot-busting medicine. At Torrance, the medicine we use is something called tenecteplase. So what that actually does, you can think of it like a blood thinner on steroids. It is a medicine designed to block and break any blood clots whatsoever. The only thing to know, and this is why we harp on coming to the emergency room so quickly when someone's concerned a stroke is happening. There's a very short window when this medicine is safe and effective to use. And unfortunately, it's only about 4.5 hours is the upper limit of that. So if someone wakes up, let's say around 8 in the morning and maybe around 9, they feel like maybe their arm is heavy or they're having trouble speaking. If someone comes in after 1 or 2 in the afternoon, they won't be eligible to get this medicine. It's not safe or effective after 4.5 hours, unfortunately. There are other treatments that we can use, and we'll go over that, but that is why it's so important to act timely when there's concern for a stroke. The other treatment that is really quite amazing is called thrombectomy. That's where a very specialized interventional doctor can actually go into the brain and pull out the blood clot. It's really incredible. And I should say this here, sometimes we actually do both. Sometimes we will give, if we're concerned someone's having a stroke, we'll give the clot busting medicine, and then if our CAT scans show that there's a big artery blocked and we can see exactly where it is, sometimes that patient will be eligible for thrombectomy, and that's where a doctor will go through either one of the arteries in either the wrist or the groin, and will thread a catheter up into the brain and actually pull out the blood clot. Now, it's similar to catheterization of the heart. It's the same concept. You enter through one of the arteries and you just go to the spot you need and open it up. And that is something that makes us a comprehensive stroke center at Torrance. Most hospitals in the United States aren't capable of doing thrombectomy. So yeah, the last thing to say is it really is a team sport. My job is pretty easy as the EI director. I just have to say, activate code stroke, and then everything gets done in the background. The CAT scan gets done, the neurologist gets called. We make the decision whether or not to give these medicines or do the thrombectomy, and then it's really our specialists that take it from there. There's a whole team, neurologists, radiologists, our physical and occupational therapists, our speech therapists. The ER is just the very first part of the process. Okay, so to wrap it up, stroke is always an emergency. Don't wait and see. Come to see us. Know the warning signs. Be fast. Call 911 if there's any concern. And then our modern treatments are quite amazing, but we do have limited time windows where they're safe and effective. And then your action changes the outcome. All right. Thank you guys very much. I'll turn it over to Dr. Chou now. Oh, turn it over to you.
Thank you. Can I do this? Thank you so much for that really excellent overview of stroke recognition and emergency response. Obviously, our emergency team are the first ones to see the patients when they come in, so they are very important in stroke recognition, and that was a very good overview. Thank you so much. So our next speaker will be Dr. Jonathan Chou from Neurology. Dr. Chou received his medical degree from University of Iowa College of Medicine. He went on to complete his residency in neurology and fellowship in vascular neurology with a focus on stroke at University of California, Irvine. He previously practiced as a neurologist at UCI Medical Center, and he's now currently our neurohospitalist here at Torrance Memorial Medical Center, as well as an affiliated faculty physician at Cedars-Sinai Medical Center.
All right. Thank you for the introduction, Hena, and welcome everybody. Thank you for having me. Tonight, the topic I want to discuss is ischemic stroke, primary prevention. Now, in our medical world, primary prevention refers to preventing a disease before it occurs. Now, this is a vitally important topic to discuss. Unfortunately, it's also a topic I rarely, if ever, get to discuss, because once patients see me, generally they've already had a stroke. So my goal here is to reduce the likelihood that any of you will ever need to see me. I would love to instead, be seeing you out in the park, out on the beach, or maybe at Costco. Before I move on further, I have no financial disclosures. We are not sponsored by Costco this year, maybe in the future. And regarding the agenda I want to discuss, we're going to be discussing or defining ischemic stroke, why this topic is important. In medical school, we have this concept of learning things through repetition. And so I know Dr. Friedrich just discussed this. I'll kind of be going over similar things. The more you hear it, the more likely it will stick. And then we'll move on to discussing primary prevention of ischemic stroke. So again, what is a stroke? It's any damage to the brain tissue due to problems of the blood vessels that supply the brain. So like Dr. Friedrich discussed, we generally divide stroke into two broad categories: ischemic stroke, which is a lack of blood flow to the brain, and hemorrhagic stroke, which is a rupture of the blood vessels that supply the brain tissue. This rupture of blood leads to injury of the brain tissue. And this topic is very important because stroke remains consistently one of the leading causes of death here in the United States. Some numbers, there will be approximately 600,000 ischemic strokes, first-time strokes here in the United States, and about 200,000 recurrent events. Again, I want to emphasize the importance of this because once somebody has developed a stroke, they are at higher risk of additional strokes. So if we can prevent that first stroke from ever happening, we can also prevent subsequent strokes from occurring. Stroke is also the leading cause of adult onset disability here in the United States. And one big thing and why primary prevention is so important is more than half of strokes can be prevented. I want to briefly touch on this this concept of TIA. You may have heard of it, otherwise known as transient ischemic attack. And TIA is stroke symptoms that come on, the stroke symptoms that Dr. Friedrich discussed, but in the next few minutes to hours do self-resolve, so the symptoms go away. And it does not lead to permanent injury of the brain. A lot of times you might hear people refer to this as a mini stroke, although technically that's not correct because a stroke refers to permanent injury of the brain. The thing here that I want to make sure to emphasize is that we take these just as seriously as a full-blown stroke. So if you develop stroke-like symptoms that then go away in the next few minutes, I don't want you to hesitate thinking, oh, I don't need to seek medical attention. The reason for that is TIAs a lot of times are a precursor to or a warning sign of a full-blown stroke. You're at high risk of developing a stroke in the next few hours to days after TIA. So even if you feel completely fine by the time you're in the emergency room, don't be embarrassed. We want to do the full evaluation and get you on the right medications for that. All right, so moving on to the second topic tonight is primary prevention of ischemic stroke. Now this is an enormous topic, something that I cannot possibly cover in the time that we have here tonight. So instead, I wanted to focus on what are the highest yield areas, those areas that even the smallest amount of change can make a big difference for reducing the risk of stroke. And this lands on the American Heart Association's Life's Essential 8. 8 of the most important aspects of lifestyle changes and medical care that we can make that will make a big difference. Now, this is not specific to stroke. It's very important for longevity, just general health. But in these next few sections, I'm going to talk about how they relate to stroke and how they relate to stroke and how they help in stroke prevention. A few things to keep in mind is that, again, with the time that we have, this is not an in-depth view of even the Life's Essential 8. It's more of a broad overview. I encourage you to, look into it yourself. If you just type in Life's Essential 8 on Google, you can find this information very easily. Similarly, I want you to be discussing these topics with your doctors. So the first of Life's Essential 8 is to eat healthy. And this is really focusing on well-balanced diets with a focus on vegetables, fruits, whole grains, beans, legumes, and lean animal proteins. These are things like chicken, turkey, fish. And then on the other hand, it's limiting those foods that cause long-term problems. So things like alcohol, processed foods, fast food, sweets and sweetened beverages. For people who are dealing with high blood pressure, salt is actually a major contributor to high blood pressure. And so for some of my patients in which this is applicable, of course, reducing salt intake is very important, but using salt substitutes such as potassium chloride can help. Potassium actually helps lower blood pressure as well. A lot of my patients will also ask me about coffee or caffeine. And really the literature suggests that caffeine in moderation is perfectly fine, safe. Now, the definition of moderation is less than 5 cups. Personally, that's still a lot of coffee, but to each their own. And then another question that my patients ask a lot of times is, what supplements, minerals, vitamins are beneficial for lowering the risk of stroke? And many different vitamins, minerals have been studied. And really, the only one that seems to suggest some modest benefit to stroke risk reduction is this B complex vitamins. This includes vitamin B6, B9, which is also folic acid, and vitamin B12. Again, in our studies, these benefits are quite modest, but there's some evidence that it helps. All right, the second component of life's essential 8 is to be active. The American Heart Association recommends at least 150 minutes of moderate intensity exercise or 75 minutes of vigorous exercise. So moderate intensity exercise, brisk walking, dancing, jogging, gardening, anything that gets your heart rate pumping a little bit. On the other hand, we know that sedentary behavior, particularly sedentary behavior above 3.7 hours per day, is associated with an increased risk of stroke. And each subsequent hour of sedentary behavior also leads to an incremental increase in the stroke risk. A lot of times when we talk about physical activity, just getting a sense of where to start, I like to talk about the 3 main components of physical activity. This includes aerobic exercise. So these are the walking, running, jogging, biking, swimming, things that increase the heart rate. This is very important for cardiovascular health. This is very important for lowering blood pressure. The second component is strength training. So body weight exercises or even lifting weights. Now, twofold benefit for strength training. One is, of course, when you strength train, you mitigate any loss of muscle, or you can build muscle. That's going to be very important for blood sugar control. Our muscles consume a lot of sugar in the blood, and so the more muscle mass we have, the better our resting blood sugar will be. On top of that, strength training also mitigates bone loss and builds bone. And this is particularly important as we age, and particularly important for women post-menopause, where there's accelerated bone loss. So strength training really mitigates a lot of that risk. By reducing bone loss, you're reducing your risk of injury, and of course injury prevents you from doing other types of activity as well. And lastly, the third component of physical activity is balance and flexibility. These are things like yoga, stretching, tai chi, very important for preventing falls, preventing injuries again. The third component is managing blood sugar. I was able to see some of the activities that were going on in the back, and so this will hopefully closely relate to a lot of the activities that were out there. But we can diagnose diabetes in multiple ways. The kind of gold standard, the best way of diagnosing diabetes is through a measurement of something called hemoglobin A1C, which is looking at your average of your blood sugar over a period of time. Other ways that we can measure blood sugar includes fasting blood sugar levels, random blood glucose levels, and then more commonly during pregnancy is the glucose tolerance test. And this is pertinent to stroke because in diabetes, every 1% increase in the hemoglobin A1C increases your stroke risk by 12%. So by controlling those blood sugars, by getting that A1C lower, you're also reducing the risk of stroke. So things that we can do from this regard is, regular checkups with your physician, focusing on your diet. I kind of touched on that a little bit. Exercise, similarly, managing your weight, avoiding smoking, getting adequate sleep, and then taking medications if necessary. This component will be pretty similar. You'll find that of the life's essential 8, they are all very much interconnected. And so there'll be a lot of repetition here. Managing weight. We have multiple methods of measuring weight, but the one measure that we use most commonly is something called BMI, Body Mass Index, but there are other methods of evaluating for obesity, including waist circumference, looking at the waist to hip ratio or the waist to height ratio. How this relates to stroke is that we see that there's clearly a linear relationship between your BMI and stroke risk. So once somebody is in the BMI considered obese, which is a BMI of 30 or above, each 5 additional units, incremental increase, leads to a 10% increase in stroke. This linear relationship is also seen when we look at stroke risk and your waist circumference or the waist to height ratio. And so similarly, things that we can look at here include portion sizes for meals, physical activity, a focus on high quality foods, increasing protein in your meal. So a lot of hunger that people experience may be due to an inadequate amount of protein intake. So just by increasing your protein, generally high quality proteins, reduces people's desires for unhealthy snacking or more carbohydrates. And then talking to your doctor or a registered dietitian for more help. Now, in these categories of obesity, so a BMI of 30 and above, something to consider is also bariatric surgery and the GLP-1 agonists. These are medications like Wegovy, Ozempic, Zepbound. Every medication comes with risk and benefits, but once the BMI generally is over 30 and there are other risk factors, the benefits of these medications in getting people down to a healthy weight, reducing the stroke risk and a lot of other health risks, the benefits of these medications many times outweighs the risks of doing so. Managing cholesterol. So cholesterol is a fat-like substance that comes from food and is also produced by your body. And it travels throughout your body by lipoproteins. You may have heard of things like low-density lipoprotein, or LDL, and high-density lipoprotein, or HDL. Now, cholesterol is absolutely vital and essential to life. All our cells are made of cholesterol, but too much of certain types of cholesterol, particularly the bad cholesterol, or LDL cholesterol, can lead to its deposition in your blood vessel walls. This can lead to plaque formation, increasing the risk of heart attack and stroke. Conversely, the good cholesterol, HDL, prevents that LDL from sticking to the blood vessel walls, reducing the risk of these conditions. And so a place to start is, of course, knowing your numbers, so tracking your levels, eating a well-balanced diet. For those of you, or for those who have difficulty controlling the LDL or their total cholesterol, reducing saturated fats such as red meats or whole fat dairy or butter can help lower these numbers a little bit. Exercise, avoiding smoking, and taking medications if necessary. The next category is measuring and managing blood pressure. So high blood pressure over time leads to damage of the vessel walls. If you think of our blood vessels just as pipes, the more pressure that these pipes experience over years can lead to damage. And this can increase the risk of heart attack, heart failure, stroke, dementia. So actually the second most common type of dementia, which is what we call vascular dementia, is very, very closely associated with uncontrolled blood pressure. So just by managing blood pressure, it can reduce the risk of certain types of dementias. But high blood pressure over time can injure the kidneys, lead to erectile dysfunction, decrease sexual arousal, and vision loss. And we call high blood pressure the silent killer, because for the vast majority of people, you do not feel when your blood pressure is high, unless it is dangerously high. High blood pressure is also probably the strongest, if not one of the strongest, direct risk factors for both ischemic stroke and hemorrhagic stroke. And so controlling blood pressure is vitally important. Again, very similar things for management, reducing salt intake, using potassium if necessary, exercise particularly, aerobic exercises, weight management, sleeping well, avoiding alcohol, and then using medications to control blood pressure as necessary. The seventh of life's essential 8 is avoiding smoking. We know that tobacco and nicotine, regardless of the method of use, directly damages blood vessels. It essentially ages the blood vessels, increases plaque formation on the blood vessels, worsens cholesterol profiles, so increases LDL cholesterol, lowers HDL cholesterol, and increases the thickness of the blood through a process called platelet aggregation. The AHA website has a lot of resources to help with quitting. The main point here is that taking a multimodal approach to quitting, which includes behavioral counseling and medications, has shown the most success in long-term, remaining off of tobacco. And then the last of life's essential 8 is getting healthy sleep. So good quality sleep is essential to brain health in general. It leads to repair of cells and blood vessels. And a more novel concept is this lymphatic drainage, which during sleep, our brain actually has the ability to remove toxins and toxic byproducts. One of these toxic byproducts is amyloid, which is the protein that's associated with Alzheimer's disease. And so getting good quality sleep is very important for keeping the brain healthy. It also helps with improving blood pressure, so indirectly reduces the risk of stroke. In general, adults should aim for 7 to 9 hours of sleep on average. And one concept that I want to bring to your attention, if you haven't heard of it before, is something called sleep hygiene, which is really focusing on behaviors that optimize sleep and sleep quality. There's a lot more that goes into this, but a few things including dimming the lights. So as we get closer to the evening, reducing the amount of bright lights that our eyes are exposed to, which these bright lights will lead to a suppression of melatonin, which is one of our hormones that are important for getting us into a state of sleep. Sleeping on regular set schedules, so going to bed around the same time and waking up around the same time every day, having a routine of winding down when we're going to sleep, and then temperature is very important, generally on the cooler side, will help with good sleep quality. One main condition that's associated with stroke is sleep apnea, something you may have heard of. It's a condition where there's recurrent episodes of upper airway obstruction during sleep. So a common feature of sleep apnea is excessive daytime sleepiness, meaning that despite getting an adequate number of hours of sleep, you still feel tired during the daytime. That can be a sign of sleep apnea. You or a partner might notice that you stop breathing during your sleep, or choke and gag during sleep may be a sign. Snoring, while not directly associated with sleep apnea, can be a symptom that suggests a risk for sleep apnea, as well as a larger neck circumference and higher BMI as well. And so this is very important, again, because sleep apnea has been shown to be a direct independent risk factor for stroke. And so making sure we have the diagnosis and treatment for sleep apnea is important. It also increases stroke risk by increasing your blood pressure. And so if that sounds like you or a loved one, I recommend talking to your doctor about getting some sleep studies just for further evaluation. All right, and so I know we kind of flew through a lot of information. If there's any questions, we'd be happy to take them later on during our question. Otherwise, I thank you so much for your time tonight.
Thank you, Dr. Chou. for that presentation. Obviously, stroke prevention is so important and something we take very seriously every day when we provide education to our patients in the hospital before they get discharged. So all of that information is very good to know. Next, we will hear from James Vargas from physical therapy. James is a physical therapist here at Torrance Memorial Outpatient Clinic in the West Tower. He earned his bachelor's degree in biology and his master's degree in physical therapy from California State University of Long Beach. He later obtained his doctorate of physical therapy degree from Western University of Health and Science. Oh, are you guys together? Oh, you guys are together. Okay, sorry about that. I didn't know. I thought it was separate. Okay, and then we also have, one second, our occupational therapist, Junith Castillo Rodstein. She's one of our occupational therapists here at Torrance Memorial as well in the outpatient clinic. June earned her bachelorate degree in biology from University California, Irvine, and her master's degree in occupational therapy from California University of Dominicus Hills. Okay, you guys.
All right, good evening, everyone. Thanks for your time. Our presentation is on stroke rehabilitation, a multidisciplinary journey across the continuum of care. So we're gonna hone in on what OT, occupational therapy, does, me, and what James does, PT, physical therapy, and what speech therapy. Unfortunately, we don't have a speech therapy with us, so we kind of summarized and we spoke on behalf of our colleagues, and we're going to address all the way from acute care all the way to outpatient setting. All right, let's get started. All right, defining the roles of OT, PT, and speech therapy.
Okay. Okay, so the role of physical therapy focuses on different things like gait, balance, gross motor skills, proprioception, joint range of motion, and physical strengths. A physical therapist will also evaluate and treat the mechanical movement dysfunctions of a patient.
So for OT, we overall evaluate and treat cognitive, psychosocial, and physical barriers to activity of daily living. We focus on the mechanical movement of upper extremity, trunk, pelvis. When it comes to sitting, standing, balance, we do include the hip and lower body as well. We include proprioception, fine motor skills, executive functioning, and environmental modifications.
All right, now the speech therapist addresses different things like physiological and cognitive functions. Their key focus is on areas like memory, problem solving, voice production, speech, clarity and articulation, language fluency, expressive and receptive language, and social communications. Okay, so now we're going to talk about the differences between physical therapy and occupational therapy, and also where there is a little bit of overlap. So physical therapist focuses on the biomechanical system. This system includes different things like lower extremity strength and stability, scapular or shoulder blade and shoulder power, arm swinging for gait and timing, so it can also affect like your balance, moving with your arms and your legs at the same time. And then balance reaction recovery, so how quickly you adapt to like a sudden change in your mobility. Physical therapists also work on transfers and bed mobility as well.
So as James said, there are overlaps. So OT is sort of a combination between physical therapy and speech therapy. We incorporate cognitive tasks, but more on the biomechanical side, there's a lot of overlap with PT, especially in outpatient and acute rehab. So just like PTs, we work on the scapula, we work on shoulder, but we work on the automaticity and the movement, the scapulohumeral rhythm. We work on the lower body, the lumbopelvic rhythm. And our specialty, we are known for our hands, right? But we do more than hands. But with the hands, we do motor control of the extrinsic and intrinsic function of the finger and wrist flexors and extensors. So we have that knowledge, and also standing, reaching out of base, and bimanual ADL and IADL coordination.
All right, now we will be talking a little bit more about the differences between, or the similarities and differences between speech and occupational therapy. So as a speech therapists work on things like cognitive mechanics. These things, cognitive mechanics include things like executive function. An example of an executive function would be regulating emotions, attention processing, or something like focus, like working on how well you focus on things, or your mental capability to focus on, or your attention on something. Working memory, and then also language and expression.
So for OT, we also work on cognition, but how it correlates with movement. So we are the application. We translate mental capacity into physical execution, and we evaluate cognitive deficits based on their ability to perform certain tasks. For example, safety in the kitchen, money management, energy conservation, and adaptive strategies. So we, just like speech therapy, work on different parts of the brain, focusing on motor control, application, and accuracy, as I said before. But the overarching goal is obviously improving the function of the patient.
All right, now we will begin talking about the different stages of rehab and the different areas where rehab occurs for patients who have had a stroke. So first stage is stage 1, priorities in acute care, or the hospital setting. So in this stage, what occurs is immediately following a stroke, the primary goal is medical stabilization. So obviously that's the ED doctors, and then if you're admitted, the doctors on the floors as well. It also includes early intervention to prevent secondary complications, so making sure that more stroke doesn't happen, or other things that are going on. During this time, evaluations by all 3 disciplines, physical therapy, speech, and OT, will occur within 24 hours of admission. So now let's talk a little bit about each discipline as far as what their roles are in that setting. So physical therapy's job in this setting is to focus on things like sitting balance, beginning to reduce neglect, which is where a patient starts to lose the ability to be aware of one side of their body. So they kind of lose that attention. Also improving body awareness, family training, so kind of educating them on what's going on and what these next steps look like, mobility and transfers. And then at this stage, depending on the stroke, we can begin things like gait training within the hospital setting as well.
All right, so for OT, positioning is really important, and it's not just how your upper body or trunk is rested while in bed. We help prevent contractures and subluxations. So being primarily an outpatient therapist, I see a lot of partial subluxation or partial dislocations of the shoulder, or even in the carpals, there might be like overstretching of ligaments, and this could be prevented right from the beginning through education, and sometimes our colleagues might ask one of the hand therapists, which we do hand therapy as well, to go over to acute therapy and just assess for a proper splint. So a lot of it's more for prevention and positioning. We also overlap with PT, and speech therapy do proprioception, sitting, standing, balance, visual, and cognitive screening. Do they need more in-depth thorough assessment for vision as well? And then also bed mobility ADLs, upper extremity function, and also determine what durable medical equipment they need, whether it's a walker or a cane, what will make them safe at this point, and also adaptive equipment to make them as independent as possible so their caregivers or family members don't have to work so hard.
All right, and now the speech therapist's role in this setting are different things like conducting swallow assessments to ensure safety, managing eating and drooling, so that kind of goes along with the swallowing assessment. A lot of times with the stroke, people or patients will have difficulty swallowing, or passing food and things like that, so the swallow exam is important, and obviously it's important to be able to eat, to be able to get nutrients, so and then providing the diet recommendations after that, so things like thickened liquids, or maybe solid foods that need to be finely chopped, things like that.
All right, so stage 2 is acute rehab. So full disclaimer, not everyone is appropriate for acute rehab, and not all insurances provide the capability for those patients to attend acute rehab. So the patient has to be able to tolerate 3+ hours of combined therapy per day. So I did work at Little Company Mary Acute Rehab, and sometimes I would see a spinal cord injury for twice in one day, and PT also twice in one day. So they might have up to 5 hours a day. So they have to actually show significant gains almost on a daily basis to keep to stay in their admission in acute rehab. The focus is maximizing their function and independence to prepare for safe discharge. So key interventions, very similar to acute, but can combine also outpatient as well because they have a little bit more resources. ADLs, IADL simulation. So IADLs are instrumental activities of daily living. So cooking, cleaning, going to the grocery store, can they manage reaching on a higher shelf, move an item and bring it to a lower shelf? Can they manage a shopping cart without falling? PT is bowel mobility, stairs, balance training. Speech therapy is memory, problem solving, voice and cognitive tasks. And OT and PT specifically work together to focus on functional endurance in the home and in the community. Again, we focus on determining their highest level of DME that they want to use. Hopefully they could progress from a walker to a cane, hopefully as long as they're safe with no assistive device. And then the supervision at home, caregiver, how much time and how much assistance they need, whether they need higher help, and also if they're appropriate for home health.
All right, now we'll be talking about stages 3 and 4. So these are kind of like our longer term care facilities, things like that. So stage 3, extended care facilities. This is kind of like here, Torrance Memorial has a transitional care unit, kind of like a skilled nursing facility, which is also out in the community. So depending on where you go, you're still kind of needing nursing care, but at the same time are also able to do a little bit more rehab. So these areas are usually patients who still require hospital level interventions, but whose progress is likely to take a little bit more time. The focus here is on gradual recovery and managing complex medical needs over a longer duration, so before being able to go home. Now stage 4, not everybody goes to stage 4. These are subacute facilities or stages, or this stage is where patients go if you're not progressing very well. This facility is for patients with highest level of dependency, so including those who are like on ventilators or who are bedbound, so can't really get up and move, or have severe cognitive issues. So PT and OT in this setting usually are there to prevent further decline, not necessarily to make further improvements. All right, so stage 5. Stage 5 is now our outpatient setting. So in this setting, we take more of a collaborative approach with all the disciplines and with our goal setting. So these goals must be patient-centered goals. So patient-centered goals are goals that are meaningful to each individual. So depending on the patient, depending on what they used to do or things like that, we want to make these goals towards them so that they have better outcomes and so they stay motivated, things like that. This ensures that all interventions are working towards the same functional outcomes and providing a holistic and efficient path to recovery for these type of patients.
All right, so outpatient OT intervention. So as I mentioned before, our clinic specifically has hand therapy. So we actually have the means to make custom fabrications of certain splints, whether it's the wrist, shoulder, or elbow. We also have availability of prefabrication splits we could offer to a patient. And this is to reduce tone, spasticity, and prep for exercise. Also, we do biomechanical approach, which is incorporation of upper extremity, trunk, pelvis, and hands, range of motion, strength training, balance, postural stability from the base up. And this is where you'll see a lot of overlap with PT. Neuro re-education, there's many approaches, and I'll go over 2 of them. And these approaches, we do a combination of everything, basically depending on the patient and their needs. and this is to retrain the neural pathways to improve motor control following a neurological injury. And then also what OT is known for is ADL and IADL retraining and making sure they could enter their community at their prior level of function and seeing where their physical deficits are, cognitive deficits, and social barriers.
All right, now going over PT interventions in the outpatient setting. So common goals here, again, different things that we've already talked about here, gait, so walking, transfers, bed mobility, family training for home. So now it's kind of a different type of training for the family. Now we're looking for things that they do at the house versus things just like basic things in a hospital setting, and community mobility. So if you're getting to that point where they're getting strong enough to start actually moving around in the community. So more specific interventions include things like strength training, balance training, dual task training is a nice one. A lot of times patients lose the ability to do two different things at once. So like it could be something as simple as like walking while holding a cup of water, making sure it doesn't spill, things like that. So we can do different things in the clinic, like a lot of times I'll try to do things like standing on a foam pad where it's uneven surface and they're having to count backwards from 100 by 3s or 4s. So they're having to do exercises mentally while they're also physically being challenged. Also managing tone and spasticity. So a lot of times patients with stroke will have a lot of tone or like spastic muscles, especially some of the more severe strokes. So managing that with stretching and education as well. Again, patient-specific care, so interventions must be specific and meaningful to the patient. So again, patient-centered goals. DME recommendations, just like June was saying. So at this stage, we also look at maybe, are you transitioning from a walker to a cane now? Things like that. So getting them to learn that, or maybe now from a cane to able to walk without an assisted device. We also work closely with orthotists. So those are people who help make braces for patients, especially like lower extremity braces that they need if they have weakness in their leg, residual weakness from the stroke. So we work closely with them to make sure that it fits properly and it works well for them. Also, again, continuing with education, so providing patient and family education on the prognosis and kind of what's to come. All right, and then as far as speech therapy is concerned, speech therapy involves a further assessment of developing things like their cognition, their speech, swallowing, and eating, and progressing that. A primary role is managing expressive and receptive aphasia, or this is the ability to speak and understand language. So this can be disrupted in patients, so they do a lot of training there to help with that. And then the speech therapist also provides assistance with things like memory, problem solving, voice production, so it could be low, things like that, and other cognitive tasks to improve communication and overall quality of life. All right, so now getting a little bit more advanced into some of the interventions that OT and PT do that we may combine and do. One of the things we do is neuromuscular electrical stimulation, or NMES. That is basically stimulating the muscles with an electrical stimulator to help recruit muscles that have gotten weak because of the stroke. So a lot of times we'll use that either like if they can just lay in bed and do some straight leg raises, things like that, or even in function while they're standing and walking, allowing it to contract while they're actually doing the movement. The other thing we do is, again, spasticity and tone management. So there's different ways to stretch spastic muscles. Also just weight bearing the limb. So like if it's the leg that's spastic, doing exercises where you weight bear on it more will also help reduce spasticity. Also subluxation rehab. So that's an example that would be like a weakness from a shoulder. If they're not able to move it, the shoulder starts to sublux, and there's a lot of strategies to help improve that too. That the occupational therapists primarily do, but there's a lot of crossover there as well.
All right, so myofascial and orthopedic related issues. So as the brain starts to try and heal itself and connect to the neural pathways to our peripheral nervous system, some muscle groups might compensate, and that's where you see tone, spasticity, and rigidity. And as a patient might get stronger in their hip, their arm might compensate and get more tone, and vice versa. So in therapy, a lot of the OTs, like myself and my colleague, will work on the hip first and then go straight to the upper body, and then that will prep also and help PT be more effective. So we address a lot of associated reaction and myofascial issues. When there's a lot of tone, there could be a lot of restriction proximally and distally, so closer to the area and further away. And there's also different techniques that we approach. So NDT and NeuroIFRA are the most two popular approaches that we use. I'm personally an NDT specialist, and the other OT is a NeuroIFRA. And typically, they don't, in most clinics, they might kind of work separately, but in our clinic, we're very collaborative, and we'll kind of go into the differences between them. So NDT, well, NeuroIFRA is a shoot off from NDT, and NDT is neurodevelopmental treatment, and NeuroIFRA is neurointegrative functional rehab and rehabilitation. So NDT, the goal is postural alignment. So aligning the hip in prep for activation. Can they increase their increase, sustain, and based on closed chain and open chain. So again, with their body weight, or when their leg is free in space, also with the arm as well. For NeuroIFRA, there's a good advantage because they go straight into real-time integration of functional activity. Whereas NDT is more slower graded, right? More a little bit slow, mechanical, and then we and the automaticity and timing, and then we progress the patient to real time. So NeuroIFRA is more realistic, everyday speeds, and they jump right into it. So there's benefit to both. One of the biggest difference is for NDT. When I did my, I guess, the fellowship in Texas, we were taught not to splint. But working with a NeuroIFRA specialist, I splint if the patient needs. So splinting is almost like their therapy at home, right? And we see our patients 1 to 2 times a week. What do they do in between? That spasticity might come, and when they do physical therapy, their spasticity in the upper body might increase because motorically they're just compensating. So there is some overlap, and with NDT there's a lot of leeway in the different approaches we could combine. And for NeuroIFRA, like I said, they have special benches, special orthopedics, orthotics. And the downside to that for NeuroIFRA is that they're pretty expensive, but the good news with our clinic is that we could kind of emulate some of that and have patients and custom make them and have their patients take it home. So then they can maintain all the progress that we have in therapy. All right, so expectations for the outpatient setting. So obviously we know that stroke recovery can take some time. A lot of our stroke patients start from acute all the way, acute rehab, et cetera, all the way to outpatient. And there's a lot of pressure for outpatient therapists because this is their sort of last stop getting one-on-one therapy. And we focus on home program progression at home. So I like to tell patients, we're gonna get you to 80%, and then you're gonna graduate, hold off on therapy, and you work on getting to a certain level, and I'll give you goals. And once you hit those goals at home, then you could be reevaluated in maybe 6 to 8 months. So the frequency of visits are very drastically with all clinics, but our specific clinic, if there's a mild stroke like a TIA, it's 1 to 4 or even 2 visits sometimes with a good home program, but probably 6 is the max. A moderate impairment would be 1 to 10 visits, okay? And then severe would be 1 to 14. Sometimes if they have really good potential and they have good caregiver support and they have transportation, it could be 16 to 20. So in my practice, I tend to get patients realistic goals so they could hit all of them, and we show insurance that they're progressing quite thoroughly, and then and I have them reevaluate in 8 months.
All right, now talking a little bit about some community resources, especially here kind of in the South Bay or in the LA area. So this is kind of talking about after therapy or after discharge from physical therapy. In our community, we actually do have a Carson Stroke Support Center. So basically what that is an area that is actually run by, I think, a professor from occupational therapy from Cal State Dominguez Hills. They take students, occupational therapy students, and they help run that. And so patients who have had a stroke, are done with therapy, can go and do more therapy. And so, and it's run by, and it's assisted by the occupational therapy students. And so they're learning at the same time as as the patients are getting more therapy. Just Right Fitness, that's another area that can help with patients maybe a little bit higher level that have come out of the stroke, that have a lot more return, so they can return to a higher level of functioning. There's also programs that insurance companies have here. Some, not all, I don't know, you'd have to check with your individual insurance, but like a Silver Sneakers program, where they either cover most of, or if not all of, your gym membership. So kind of returning to doing something like that, and the therapist can work with you discussing what exercises you can do at the gym so that you can kind of go and be independent there a little bit. Modified yoga and Pilates. There's a lot of yoga and Pilates instructors that can modify the yoga and the Pilates to stroke survivors. So that's definitely appropriate, especially for stretching and things of that nature. And then lastly, what I'm going to talk about is the Long Beach State Pro Bono Clinic. So I'm a Long Beach grad. Even when I was going to school there, we had the Pro Bono Clinic. So again, it's DPT physical therapy students that also will treat patients who have finished formal physical therapy, and they're students who are also learning, and they'll get like twice a week therapy as well there, because they kind of do it between two different students. So it's kind of a nice program as well.
Okay, and then also stroke support groups is also a way to get resources and discuss with peers and other patients. So to support our South Bay community, Torrance Memorial, we have a stroke support group on every second Tuesday of every month from 10 to 11 a.m. at the Hoffman Health Center, so which is across the way. And my colleagues Tammy and Maria kickstarted that. And just last month they had a speaker that they involved, and it was a psychologist that talked about the emotional recovery and how to cope with experiencing a stroke. So both on the caregiver's perspective and also from the patient. So they found it very helpful.
All right, so with that, thank you guys very much for being here. We're grateful for
Thank
your
you.
time. Yes, these are, we have our names up there and our information, so feel free to give us a call anytime and discuss different things. So, all
Thank
right,
you.
Thank you.
Okay, thank you, James and June. Obviously, rehab is such an important part of stroke recovery. It's something that we tell our patients all the time, that majority of the recovery is going to come from doing really extensive rehab outpatient. So thank you for that. And also thank you to all of our speakers that came out tonight with all of that really important information, and all of you who are so interested in this topic. So we are going to ask everyone to write down their questions if they have any. So we'll give you guys a couple of minutes to write down your questions, and then we will ask.
Higher the number of reps, the worse the loss. Higher. So now it's not a lot of muscle, muscle more dense.
I think I can walk you through that a little bit. I don't know. Do you want me to adjust that?
Okay, I'll just give everyone a few more minutes to write your questions.
Okay. I can't stay too much longer. You have a card or something? But anyway, but muscle is more dense. Yeah, like that's better for you.
Where it starts to fall is actually the so, a very well-built,
It's like a false negative.
So this is why when that's we actually use those.
But then that's a good condition to have, though. Because you're healthy.
Exactly. But yeah, it's just the athletes who are overweight or this range. If you look at them, you're not going to say. There's a lot of these populations tend to have a lower muscle mass per body weight, and so the regular cutoff for the BMI, 25 and above being overweight, actually under this.
Well, because of the fatty, a lot of fat, that's kind of like not as dense. It's more porous.
Exactly.
Yeah, so maybe we need a better metric. Huh?
So this is why actually, we combine BMI with weights
There's no one
Thank
thing
you.
Yeah.
As a population, it's a good measure. Meaning if BMI is high, on the whole, people are more likely to have stroke. Yeah. But
The devil's always in the details when we get
but
down
on
to
the
the
individual
individual.
level,
Yeah.
And this is why it's 20 minutes.
I know. These are good. I mean, I'm really glad you guys do that. It really helps. And actually, a question for the group. When you guys do your therapy and stuff, when you're trying to find out, basically, patients.
Okay. Okay, so if I can just have everyone take a seat, please.
Basically, see how the brain is healing. I know they're kind of expensive, but
If I can just have everyone take a seat.
there's a lot of research.
Thank you.
Right. Yes. Because I think that's the next big thing. So
You're ready to start.
right.
Okay, so there is some few questions that came from our Zoom. One of them is, okay. Is there any first aid I should perform on my loved one while waiting for paramedics?
Okay, that's a great question. So for strokes, there's nothing that really comes to mind for me other than making sure your loved one is in a safe place. If they're having trouble breathing, trying to sit them upright. It's not like if someone loses pulses and we do CPR, I'm trying to think, I don't think there's any equivalent like that for a stroke, just keeping the patient or your loved one safe until paramedics arrive would be the thing I would recommend to do. It's a good question.
Yeah, I think the best thing to do is call 911 right away. So another one is, can you have a stroke and not feel it? Yeah.
Absolutely. So, is this on? There's a concept called silent strokes, actually, which is, first of all, the importance of a stroke is actually based off of the location. It can be a very small stroke in a very important area that causes complete paralysis on one side of the body. Can you not hear me? Okay. How about now? Okay. So I was saying, the stroke location is very important. So if you can have a relatively large stroke in a part of the brain that doesn't contribute much to what we call motor function, so you may not feel it. On the other hand, if you have a very small stroke in a very eloquent area, it can be quite devastating. And so we do see this quite often where, especially back when I was doing more clinic, I would get referrals from people who just get an MRI for a completely unrelated reason, find a stroke on the MRI, but them thinking back, they've never experienced stroke symptoms. As of now, it's really hard to say what we do about those situations. Obviously, once we see a stroke there, we treat it with all the same medications to reduce the risk of further stroke. But we don't have any guidelines right now that suggests, screening MRIs for everybody. But absolutely, you can have what we call a silent stroke, which again is different than a TIA as well.
Okay, thank you. And another person asked what prescription medications are required for future strokes. The medications we put patients on after they have a stroke are aspirin and Plavix. Those are usually secondary stroke prevention medications once you do have a stroke. But is there anything else that
I can touch on that a little bit more. So, the area where I counsel more often is what we call secondary stroke prevention. So once somebody has had a stroke, what can we do to reduce the risk? Now, exactly like Hena said, the common medications we use are certain types of blood thinners, and aspirin is a very common one. And so, actually, I get this question quite often of, if somebody at home is experiencing stroke symptoms, should I just give them an aspirin right then and there to try to help the situation? The problem with that is we don't know if the stroke that they're experiencing is actually a hemorrhagic stroke, the bleeding type of stroke. And so by giving them an aspirin, you could be potentially making the bleeding worse and causing the situation to be worse. So in these situations, we don't recommend trying to give them any medications when somebody develops a stroke symptom. 911 is the important thing.
Yes, and another person's question was, if you think someone is having a stroke and you're not sure what to do, you're not sure if it's a stroke, what should you do? And it's to call 911, the best thing you could do. And if you're not sure, just call 911. The next question is, can you talk more about the emotional recovery of someone who requires acute rehab after his or her recovery is slow? I'm gonna read to rehab. I guess they want to know more about emotional recovery after stroke.
So emotional recovery, we usually defer to a psychologist, but speech therapy touches upon it as well. Patients after stroke, depending on how severe, can be a little bit labile and things are a little bit heightened. They're also dealing with potentially a new personality. So it's technically out of OT and PT's scope of practice, so we always want to defer to the best person, which is their doctor and the psychologist.
Okay, thank you. This one is, please explain the risk of blood clot causing a heart attack or stroke after surgery.
No, go ahead. So sorry, can you repeat the question again?
Please explain the risk of blood clot causing a heart attack or stroke after surgery.
So I'm going to try to clarify it a little bit. So after someone has a surgery, the body can be more prone to having a blood clot. Now, typically, I don't know if that's associated with increasing risk of stroke. We see that in other places. Sometimes you can get a blood clot in the lungs. To your knowledge, Dr. Chou, could it increase risk of stroke? Surgery?
Yeah, absolutely. But to your point, I think venous blood clots are much more common post-surgery.
Yeah. So when someone goes to surgery, they're immobile in the hospital, and just the process of getting an operation can predispose blood clots to form. So there can be elevated risk of blood clots forming after surgery.
If you suspect someone is having a stroke, what position should they be while waiting for paramedics to arrive? Just whatever position you found them in.
Just stay
Yeah.
seated. Yeah, whatever keeps them safe until paramedics come.
Yeah. And then also how much of alcohol consumption, what is the recommended alcohol consumption to for a healthy cardiovascular system? I don't think
Yeah.
there's.
So I think the question is,
To maintain a healthy cardiovascular system, how much should I drink?
yeah.
How many glasses of wine should I have a night?
The devil's always in the details, right? So I want to share with you actually what the literature suggests, which is, in ischemic stroke, there's something called the J-shaped curve, which actually indicates that there's lower stroke risk, ischemic stroke risk, with low levels of alcohol use. So no more than 1 drink a day actually seems to show some protective benefit in our research. However, on the hemorrhagic stroke literature, it's actually a linear curve. So each additional drink increases your risk. So, from that standpoint, 0 to 1 drinks a day at most. As a neurologist, though, the other thing I see is patients with, for the diagnosis of dementia. And we know that no amount of alcohol is safe for the brain. It is a neurotoxin. Now, I'm not here to remove all joy from your life, but, if you wanted me to quote a specific number, no more than 0 to 1 drinks per day, maybe a few times a week, 2 to 3 times a week at most. And hopefully it's, in the context of social activity, which actually has been shown to be very protective and beneficial for the brain.
This next one is a good question. What is the difference between TIA and a syncope, which we see very often in the hospital? So TIA versus syncope.
Yeah, that's a good question. So the medical term syncope means to faint. So anytime someone has a fainting episode, so a loss of consciousness, a lapse in consciousness, that's what we call syncope. And so sometimes if someone is having a large stroke, potentially they could have a fainting episode involved with it. But typically when someone's having a fainting spell, as long as when they wake up, they're intact, using their arms, hands, speaking normally, using their arms and legs normally, typically those are 2 unrelated incidents. Does that sound fair? Okay. Good question.
This one, I could probably answer this one. If a person's systolic blood pressure reading is between 130 to 40 over time, what should you do? American Heart Association actually recommends, in patients who've had a stroke, their long-term blood pressure to be less than 130 over 80 at home. Blood pressure of 130 to 140s is a reasonable blood pressure. Obviously, we always recommend you guys to keep a log of your blood pressure, and if it's consistently high, then you would need to see your primary care physician to see if they would either need to increase or add on blood pressure medications. But for our stroke patients, normally we recommend a blood pressure of 130 over 80 and to monitor your blood pressure every day at home. Wait. Let's see. This next one is how many hours of sleep is needed? Can I supplement naps instead of sleeping? How good are naps? Naps are great, but sleeping throughout the night for at least 8 hours of sleep throughout the night is recommended.
Yeah, the recommendation is on average 7 to 9 hours, and so some nights here and there where you get fewer hours is fine if you can make up for it. Naps are okay. If you're taking very long naps, during the daytime, there may also be other reasons why. Going back to things like sleep apnea. There are conditions where despite sleeping enough, you feel exhausted during the daytime. And so if you are still taking a lot of naps during the daytime, I would recommend just talking to your doctor further about that, seeing if there are additional tests that you can do. If that just is a pattern of behavior that you're used to for years and years, that may be completely fine as well.
I was just going to add on to what Dr. Chou said. It is normal to experience sleepiness in the afternoon. A lot of cultures take a siesta in the afternoon across the world, so it's normal to have a little dip in our alertness. And that's not necessary. There's nothing wrong with taking an hour nap, but like Dr. Chou is saying, if you're excessively sleeping throughout the day, that might be worth looking into.
I also want to add that you want to go into REM sleep, and I believe the most recent literature, I don't know how many hours, but that's a certain amount of hours needs to be taken to go to REM sleep and for lymphatic drainage. So that does not happen within an hour, hour and a half. I think it's surplus, because I remember telling a patient that, but I have to read back on the literature.
And actually, I also want to add that, like they're saying, naps are fine, but as long as it's not then disrupting night sleep. So the night sleep is the most important sleep, the straight 7 to 9 hours of sleep. You can, I guess, supplement with the nap, but as long as like a nap is not affecting you, so where now you're only getting like 5 hours of sleep at night. So you still want to get that long period of or a long period of sleep at night.
And then this is also probably another question for rehab. What is proprioception in physical and occupational therapy?
So proprioception, so basically there's receptors in all of our joints, even like the tiny little joints in our fingers that give input back to the brain that tells it where it is in space. So as far as it relates to like balance and things like that, so our knees, our ankles, our hips, there's receptors there that send impulses back to the brain that tell the brain where it is in space. So a lot of times with any kind of injury, even like an ankle sprain, things like that, we want to train the proprioceptive system, so working on balance and things like that, so that it gives input back to the brain so we know where it is. So it's obviously vital with stroke patients because potentially for a while they lose ability to move an arm or move a leg, and then as the stroke recovers, obviously things get better, but it's not quite as good as it was before, so you want to retrain that. So it's basically giving input through either an arm or a leg that gives input back to the brain, so it senses kind of where it is in space for not just balance necessarily. I mean, I spoke a lot about balance, but just for appropriate walking or movements or turning, twisting, things like that. So, good question. Oh, you want to add?
So proprioception actually tends to get a more faster recovery in the lower body. So as soon as you have a stroke, you get acute rehab, and the first thing you do is sit and stand, right? So weight bearing, as he said, input to increase those signals to the brain. So the upper body, the affected side, sometimes unilateral or bilateral, will take some time. So the upper body is actually really one of the hardest to regain in terms of function and automaticity and accuracy. And it's, unless you are a gymnast before and you're going to have a stroke and you're going to walk on your hands, you need to get that excess proprioception. So that's why all these modified yoga, Pilates, anything using body weight will kind of make up for that imbalance that you might get more on the lower body.
And then, thank you. I think this one is also important, is one of the symptoms of hemorrhagic stroke a severe headache? And that's, yes.
It definitely can be. So patients can present to the emergency room with severe headache and can have hemorrhagic stroke. Other times it can be non-painful as well, but it can certainly be painful.
And on that same topic, are aneurysms related to hemorrhagic type strokes?
So aneurysm is a little bit different, but although they share some similarities. So an aneurysm is a ballooning out of the blood vessel wall that can rupture, leading to bleeding. But typically the bleeding that occurs with aneurysms bleeds into a different space compared to when blood vessels rupture inside the brain. And so with aneurysmal ruptures, a lot of times that presenting symptom is very, very severe headache, but you may have no weakness, numbness, no stroke-like symptoms. And so severe headache, especially if you're not somebody who's prone to headache, is also a very valid reason to seek emergency medical care.
Another question was that is secondhand smoking one of the part of one of the life essentials, and I think
Yes, direct smoking as well as exposure to secondhand smoking you experience the same, damage to the blood vessels. They include secondhand smoke in this literature as well.
just smoking in general not good for you. Are saunas good post-stroke for prevention? I don't think there's any literature on saunas that would prevent you from having.
Are they after stroke, whether it's
Should
okay
I go to the sauna to prevent strokes? And the answer is it doesn't really affect.
Yeah.
Or if it's for recovery and if it makes you feel better.
Right, I was going to say, maybe I'm not understanding the question, but after stroke, I mean, obviously if you're on different medication and things like that, that make sure that you maintain your blood pressure low or, normal. It could aid in kind of loosening up some of the muscles after a stroke from spasticity, but as far as whether it's preventative, I don't know if there's anything that really says it prevents you having a stroke, like before having a stroke, yeah.
And actually, so I don't know the literature behind recovery and stroke, but in terms of prevention, one of the things we counsel our patients after a stroke is really to avoid dehydration, which, especially if your stroke was due to, plaque buildup and narrowing of blood vessels, dehydration can actually worsen or cause new strokes. And so just imagining, being in a sauna for too long, if it leads to dehydration, can actually precipitate a stroke. So I would urge caution on that.
Yeah, definitely hydrate if you're going to the sauna. And I think that's all of our questions for tonight. Thank you everyone for coming. It was a pleasure to have you guys here, and thank you to our speakers. Have a great rest of your night.